Hello everybody. Let's start with our discussion on button battery in gastrointestinal tract. I'll be discussing some basics about foreign body in gut and then proceed with button battery ingestion and how to manage them. So foreign body and button battery. These are our topics of interest today. So if any question on button battery or a magnet or any sort of foreign body is asked, start with an introduction. So in introduction, what will you be saying? You will be saying foreign body ingestion is a very common condition that you see in your day-to-day practice. It is most common in which age group? Toddler age group. Why toddler age group? Because they are naturally curious. They have accessible unsafe items. The availability of such items, it's not enough, it's accessible, no? It has to be available to them. And the attractiveness of the item. All of these together contribute to the foreign body accidental ingestion in toddler age group. The decision to observe or remove a foreign body will depend upon many factors. So what factors are they? So factors determining observation versus removal. Now we are talking about a general setting. Alright. So what will determine it? It depends upon what foreign body it is. Correct? Then how many foreign body was consumed? One, two, more than two, right? Then the location of the foreign body in the gut, whether it's in the esophagus or whether it is down below. Then whether it is mobile or not. Mobility of foreign body. Then how long the time has elapsed since the ingestion of foreign body? Time elapsed. How can you remember this? What foreign body? When was it consumed? Where is the foreign body now? How is the nature of the foreign body and how many foreign body? And whether it is mobile. That is your where, I guess. Right? So your mobility and location will come under your where. Then what foreign body, nature of foreign body, when was it consumed, and how many have been consumed. So all W questions if you put, that will determine um, line of management. The common foreign bodies are magnets, button batteries, coins, toys, small jewelry items, then food items which are absorbable. And clinical features depend upon the nature of foreign body, size of foreign body, etc. The timing of foreign body removal, if you see, it is generally divided into emergent, urgent, and elective. What do these terms means? See, my class today is basically from North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. All right. So that is my basis for today's class. So timing of removal of foreign body is divided into three. One is emergent. When you say emergent, it's less than 2 hours time from presentation. Okay, not time since ingestion, time since presentation, irrespective of the NPO status. When you say urgent, it is less than 24 hours from presentation and you will follow the NPO rule. NPO is nil per oral. You are not going to give anything to the child orally. Elective is after 24 hours from presentation and you will definitely follow NPO rules. This is the terminology for removal. So previously we discussed the mobility of foreign body and time elapsed since the foreign body was consumed, right? So why was I discussing that? I was discussing that because normal transit time for a foreign body in gut is around 3.5 days, 3.6 days. All right, so normal transit time. So, if any foreign body is immobile or there is no progression of the foreign body from where you saw last, after 3 days also, after 3 days, no progression or no movement, then you call it as non-transit. All right, non-transit. And it has to be acted upon. You don't expect it to move. So you follow it up through X-ray to see whether that foreign body is moving or not. So this is in general an overview about foreign body ingestion. So let's talk about button batteries, and why are we talking about button batteries? Button batteries. So button battery ingestion, what is the importance? See, the importance of button battery lies in the fact that it causes injury, erosive injury, caustic injury, right? That is why we are worried about. So what is the mechanism of action? The hydroxide radical that is produced results in caustic injury to mucosa. Okay, caustic injury to mucosa. And it's not enough if you just remove the battery, you still have to observe because injury continues to happen even after removal. See, that's the thing with alkali. All right, so if you consider an acid versus a alkali injury to mucosa, acid causes something called as coagulative necrosis, pathology. All right. Your alkali causes something called as your liquefactive necrosis. Why am I talking about pathology now? See, coagulative necrosis will result in a thick uh, leathery layer in the necrotic part. So that will prevent further action, further injury from the acid that was consumed. After the initial injury, it does not proceed further beyond this thick leathery part. Whereas in alkali, liquefactive necrosis, there's no leathery layer that is forming. So there's no coagulative necrosis that's happening. What is happening is a liquefactive necrosis. So the injury is generally deeper and more severe in an alkali consumption compared to that of an acid consumption. So button battery's mechanism of action, yes, hydroxide radical resulting in caustic injury. Injury continues to happen even after removal. And always remember, a newer battery will carry more power, so it poses 3 times higher risk compared to that of older batteries. So that is something you have to ask. So when a child is coming to you with button battery consumption, you will ask the usual W questions. How many was consumed? When was it consumed? Where was it consumed? Where is it now? So all those things you'll be asking. Apart from that, you will ask these questions: new one or an old one? Mind you, old one also will cause injury, but the new one can cause 3 times increased risk compared to that of a old battery. Then size of the battery. All right, why is size important? Size of the battery is important because the bigger size can cause an impaction in the esophagus. All right. So high risk of esophageal impaction is present if the battery is big. And also size of the battery will determine your line of management if it is going to go beyond your esophagus. I'll discuss about that in a minute. So this is the importance of button battery ingestion. What complications do you fear most? So a child is coming to you with button battery ingestion. What is it that you are most worried about? Your most feared complication is aortoenteric fistula. So, since this is an alkali, it can erode through all the layers of the intestine, esophagus, or your stomach. Esophagus is what you are most worried about. It can result in an aortoenteric fistula. It can result in tracheoesophageal fistula. It can happen in 48%. Then it can result in an esophageal perforation can happen in around 23%. It can result in esophageal strictures. Okay, so this can happen in around 38%. You don't need to remember the percentages. This is just for my interest's sake. I'm putting it across to you. And this is not very difficult to remember. So let's see how to remember. So you have your esophagus, no? So this is your esophagus. It has multiple layers. You have the button battery sitting here. Correct. So if just till muscle layer is involved, all right, not whole is involved, only till muscle layer is involved, then this will result in a stricture. Correct. Suppose this whole, all the layers of trachea, no, I mean your esophagus is eroded, then what will it result in? This will result in an erosion and perforation finally. Correct. Suppose it is very close to the trachea. All right. So your trachea is sitting here. So if this is going to come in contact with your trachea, trachea can also get eroded, resulting in a tracheoesophageal fistula. Correcta? Hmm? So if it is going to go beyond, so it's working above and beyond what is expected, then what do you expect? You have your aorta. Correct, you have your aorta. It can result in a aortoenteric fistula. This is just a diagrammatic representation for you to remember easily. Okay, so these are the complications that you expect. So how are you going to investigate a child who is going to come to you with a button battery injection? So you are going to investigate to see how many are there. Is it actually a button battery or is it something else? Okay, let's see about that one by one. So investigations. Investigations, you will do one, a X-ray, chest and abdomen. Because you do not know if it has crossed the esophagus and gone into stomach or small intestine, right? So you get both. What are you going to look for? Your main issue is to differentiate it from coin. Okay, how are you going to do that? In your anteroposterior view, in your AP view, you will see a double halo. So there will be two borders that you'll be seeing in your button battery. So this will be in your anteroposterior view. Whereas coin does not have this double halo. Okay, so this is called as double halo sign. Then in an X-ray lateral view, what you will have is a step off. Okay, so what do you mean by a step off? So this is the back of the battery. It will look something like this. Okay, so something like this. So this is a step off. All right. So this is a step off depending upon how the battery is. So if the center part is bulging forward, then your step off will look like this. If the center part is depressed, then your step off will look like this. But you get my point, right? So lateral view will have a step off. So this is a step off sign. This will not be seen in a coin again. Alright, so this is why you do an X-ray. Apart from trying to find out how many and where. Then MRI you will do if you are trying to look for proximity of injury to aorta. So you already know there is an injury, but you want to know how close is it to aorta and is it going to pose a risk. Proximity of injury to aorta. You can do a CT angiography if you are suspecting an aortic injury already. I have simplified this for ease of remembering. It's actually more complicated than this, but yeah, this should do for you to understand the basics. Now, investigations, everything you have done. Now you have to remove the battery. Are you going to remove the battery in all patients? So that is the next question. Okay. Removal of button battery. Removal of button battery. is it going to be done in all patients? Whom can you observe? So, observation can be done in patients who are coming to you within 2 hours of ingestion. Size of battery is less than 20 millimeter, and few of the indications I'll be talking about now. Absence of clinical symptoms, asymptomatic patient, that is. Child is more than 5 years, plus some of the things in flowchart I'll discuss down below. So you will observe if the child is less than 2 hours from ingestion, less than 2 centimeter battery size, more than 5 years child, and absence of clinical symptoms. So if the button battery is in the esophagus, your management varies. If the button battery is in the stomach or small intestine, your management varies. So let's see both of them separately. First is button battery in esophagus. If you ask my son, he will say esophagus, esophagus, as if he has gone to, Western countries and studied and come back. Right. So button battery in esophagus, you'll see if the child is hemodynamically stable or unstable. Either way, you're going to remove it endoscopically and you will remove it urgently. There's no doubt about it. All right. So button battery in esophagus is urgent removal. You're going to remove it endoscopically. If the patient is hemodynamically unstable, in an unstable patient, during endoscopy, you will look to see if there is an injury, if there is an esophageal injury. If the injury is present, you will keep the patient nilperoral and you will do a CT angiography and MRI chest. Why are you doing that? You are trying to see whether the injury is close to aorta, and if aorta is injured, you will alert cardiothoracic surgery and keep them in standby. Keep them close by, because if intervention is needed, they are the ones who are going to open up the chest. Alright. So, இது பார்க்கறதுக்கு abort மாதிரி இருக்கு. Let me write it again. Alert. So you do this CT angiography and MRI and you see that there is no injury and it's not very close to aorta. So in that case, you do a esophagogram to make sure there is no leak. Only if there is no leak, you will plan to initiate an advanced diet. You have to start some food. No patient is NPO, correct? So this is how you proceed in a patient who is not having an injury while you check through CT angiography and MRI, not having a problem in esophagogram, there's no leak. All right. So suppose you find some injury. Injury is close to aorta or the aorta is already injured, then the course is clear. Cardiothoracic surgery is going to take over. But if the injury is close to aorta, what are you going to do? You are going to give rest. You will continue NPO status. You will give IV nutrition, antibiotics, and serial MRI will be done. Okay, serial MRI. Every 5 to 7 days it can be done till injury is seen to move away from aorta. Every 5 to 7 days till injury recedes from aorta. All right. So this is how you manage a patient who's having a button battery in the esophagus. So esophagus urgent removal, endoscopic removal. If patient is unstable, you will look for esophageal injury through endoscopy. If there is injury present, you will keep the patient NPO because you do not know the extent. No, whether it is just serosa, whether it is mucosa, whether it has perforated, whether it has gone to aorta, you do not know. Correct? So that is why You check for the most serious first by a CT, angio, and MRI. If that is not there, you will look for the next serious with an esophagogram. If that is also not there, then well and good, you can slowly initiate diet and advance. If you find something close to aorta, then keep the patient NPO, monitor, and follow up. And remember, any patient who's coming within 3 weeks, okay, within 3 weeks with hematemesis, always suspect injury. All right. Within 21 days, within 3 weeks, patient is presenting to you with hematemesis or upper GI bleed, fresh or altered, does not matter. Assume aortoenteric fistula and prepare for emergent thoracotomy because it has to be investigated. All right. So a button battery injection patient, you discharge, they are coming by 2 weeks or 3 weeks with hematemesis. Think of aortoenteric fistula. So this is about the foreign body or button battery in esophagus. What about button battery in stomach or small intestine? So stomach or small intestine depends upon age of the child and size of the battery. Okay. If age is more than or equal to 5 years, or note that this is or, okay, this is not and, or the size of the button battery is less than 2 centimeter, then you can consider observation. One of the indications, correct, for observation. Consider observation. Now you find out that the size is more than 2 centimeter and you are not very comfortable. You watch the child more closely compared to a smaller size button battery. All right. So what is it that you're going to watch? Whether it is passing in stools or not. That's all. You will continue observation, but more frequently. So if a button battery size more than 2 centimeter has passed within 48 hours, it is good. So this is what you generally expect. If it is not passed within 48 hours, then repeat X-ray, and if it has not progressed, then you can endoscopically remove. Okay. So this is about a button battery more than 2 centimeter. If it is less than 2 centimeter, you can even wait till 2 weeks. Okay. So 2 weeks if it has passed, then it is fine. If it has not passed, then you do an X-ray and endoscopic removal. All right. So 2 days, 2 weeks, 2 centimeters. Multiple twos are there. All right. Remember that. So this is in a child who's above 5 years. So let's keep it as simple as that. So above 5 years, you observe the child, whether the size is more than 2 centimeter or less than 2 centimeter, you give them time to pass it in stools. If the size of the battery is above 2 centimeter, you wait for 2 days. If the size is less than 2 centimeter, you wait for 2 weeks. Beyond which point you will remove it endoscopically. All right. So next, A, the button battery is in the stomach or small intestine, and the age of the child is less than 5 years. And it's not an or, it's an and. Button battery size is more than or equal to 2 centimeter. Then you will do a urgent endoscopic removal. Hey, wait a minute. Esophagus, I told urgent, no? It's emergent, pa. I'm sorry. So it's not urgent, it is emergent. Please correct it. All right, I'm extremely sorry. This emergent. I meant emergent, but வரும்போது urgent ன்னு வந்துருது. So urgent endoscopic removal in a child whose age is less than 5 years with button battery consumption of more than or equal to 2 centimeter, and you will assess for esophageal injury and then proceed accordingly depending upon if the child is symptomatic, asymptomatic, hemodynamically stable, not hemodynamically stable. So that's it about your button battery injection. So if you write this much, you can end with your complications. All right, so you can say the you can put a small introduction mechanism of your intro, mechanism of action of your lithium button battery. All right, then you can say the presentations, whether patient is symptomatic or asymptomatic. And then you can say investigations, what investigations you are going to do, why you are going to do, what are you expecting. Then treatment, depending upon whether it is in the esophagus or in the stomach. Then end with complications. And prevention, you can always add a word. For every question, if you can write a prevention, it will be well and good. All right. So prevention, things need to be kept out of reach, and button battery should not be given to children for play. It is not safe. And early recognition is important in preventing morbidity. I think this much, if you write, it is more than enough if they ask such a question. And for management also, if you know at least this basic, you know when to refer a child, that's good enough. So thank you for listening to me. Share this lecture with your friends if you found this useful. Thank you all. All the best for your exams. Let's meet tomorrow. Bye bye.